start by apologizing because I fear that I may raise more questions than provide enlightenment. Here are my disclosures. And so this is, we've had a lot of discussion this week about the different mechanisms in the pathophysiology of antibody-mediated rejection, the role of NK cells, the role of antibody-dependent cellular cytotoxicity, complement activation. And we know that all of these elicit a context of inflammation with cytokines in complement, leading to myeloid and T-cell diapedesis into the graft. The role of non-HLA antibodies is still being studied. AST STAR working group has determined that we still don't know how to interpret non-HLA antibodies in the context of ABMR, whether they are contributing to the injury, an active contributor, or whether they are a biomarker of allograft injury. And so I'll begin. I tried to avoid studies that I thought Stan would cover in his talk, with the discussion of, in chronic ABMR or late ABMR, it appears to occur with and without DSA detected at time of biopsy. And this is a paper from Germany showing that whether DSA is detected or not detected at index biopsy, they have similar allograft survival. And this was different from this study from Martin Nason's group, which showed that DSA positive biopsies, shown in red, had a lower graft survival than HLA DSA negative biopsies. However, in this study, I wanted to point out that the DSA detected was both persistent preformed DSA, because these involved HLA incompatible transplants, as well as de novo DSA. They lumped them together as DSA positive, and perhaps that is why we're getting a different signal from this study. Dr. Jordan just presented that they did not see a higher incidence of, they saw greater graft loss with de novo DSA rather than preformed, but I believe the Hopkins and Mayo Clinic both published that increased in early transplant glomerulopathy with HLA incompatible transplants, and I think it depends on the titer of the DSA at transplant and the strength of the DSA that persists post-desensitization. But this is my favorite figure from the Nason's publication, where it really shows strikingly that the active acute lesions are quite different in DSA positive versus DSA negative biopsies, whereas the chronic lesions are really indistinguishable between these two serological positive and negative patients. However, the transplant glomerulopathy diagnosis of HLA DSA positive biopsies did show higher microvascular inflammation and cumulative inflammation, and these patients were more likely to have a previous biopsy showing microvascular inflammation or ABMR. And so, what is the role of HLA DSA in chronic ABMR, knowing that we have multiple contributors to the type of injury observed on biopsy? I think there is evidence that in the case of HLA incompatible transplant, that DSA likely does contribute to early transplant glomerulopathy. But my question is, do all class 2 de novo DSA lead to TG eventually? And is it that when we detect the DSA without histological lesions of chronic ABMR, is it that we're just looking too soon in the process? And is transient de novo DSA sufficient or necessary to initiate chronic ABMR? Could it be after 1 year we're not monitoring for DSA frequently in our patients, perhaps yearly at best? And is there a transient de novo DSA that's sufficient to initiate this process of tissue injury? And can the DSA go away? And that's what we're detecting in DSA negative chronic ABMR. And so this is a different study with chronic ABMR treatment out of University of Wisconsin. They looked at 82 consecutive chronic ABMR cases. The mean time post-transplant was 10 years post-transplant. And they looked at treatment response with pulse steroids, IVIG. Some of the patients received rituximab, some did not. And similar to other studies reported by Dr. Jordan in the previous talk, those that responded had a better graft survival, and the non-responders shown in the dotted line had a much worse. Response to therapy was looked at 3 months, and the criteria were an EGFR that was within 10% of baseline, proteinuria decline of greater than 25%, DSA decline of greater than 50%, and complete elimination of microvascular injury. And so we do see a decline in DSA that correlates with a increased EGFR. This is showing patients with or without rituximab. The rituximab is in orange, and they did see at 3 months better return of EGFR and a greater decline in DSA. However, interesting, from their table, at time of surveillance biopsy, so biopsy after treatment, they did not see any efficacy of rituximab treatment on the EGFR or the DSA response, such that it took time for the effects of rituximab to take a hold. And so, more questions. Is HLA-DSA testing at time of chronic ABMR diagnosis or after treatment? Is it useful? Does it tell us anything? Does DSA perpetuate chronic ABMR in an active way? Do we need to see consistent presence of DSA? As I just showed you, a decrease in DSA does correlate with improved EGFR, suggesting that perhaps it does have an active role in chronic ABMR. However, in the Wisconsin study, they did not eliminate all of DSA. There was still, while they got a significant decrease in DSA of greater than 50%, there was still DSA in circulation. So the microvascular injury resolved completely without complete elimination of de novo DSA. So does that counter the hypothesis that DSA is still continuing to have an active role in chronic ABMR? Does the DSA MFI or titer, is it meaningful? Does it dictate time to transplant glomerulopathy? And is DSA irrelevant once this process has been initiated? This is a study which also treated 67 patients with chronic AMR. They had the opposite finding in that 21 patients treated had worse allograft survival at 3 years. To highlight, these patients were treated perhaps more aggressively than the Wisconsin group. They received 6 sessions of plasmapheresis and IVIG, and patients who received this therapy had significantly more infections, which may have initiated perhaps a more pro-inflammatory milieu that portended worse allograft outcome. So detecting, monitoring, reporting, I thought I would bring it back to a case study and elicit some discussion. I think I think it's well known of the assays that we use in the HLA laboratory. We have multiple different Luminex-based tests to be able to really detect DSA at very high sensitivity and high specificity. And so I thought I would bring a clinical case back to the clinicians. This is a 36-year-old Caucasian male with end-stage renal disease secondary to minimal change glomerulopathy. He was non-sensitized. This transplant was performed preemptively with a living donor. He had immediate and excellent allograft function with his serum creatinine declining, no induction therapy, and immunosuppression with Prograf, MMF, and steroid taper. This shows the HLA typing, and for the HLA colleagues in the laboratory, in the audience, when we look at DR and DQ, this is not a bad mismatch. He is mismatched only for DR1 and DQ5, but DR12 mismatch is very related to the DR11. He shares a 52 with the recipient, and they share a DQ7. So overall, it's not a bad HLA mismatch. So his clinic visit at year 1, His serum creatinine baseline is 1.5 to 7, no proteinuria. He tested as DSA negative. I think this was during COVID. I don't know what happened to year 2 visit, but routine clinic visit at year 3, serum creatinine is stable. However, when he came to clinic, his morning bloods draw did show an increase in serum creatinine of 2.0. There was some discussion in the medical record note about perhaps missing some doses of immunosuppression. They performed an HLA-DSA assay which showed de novo DQ5 DSA at 5,000 MFI. Would you biopsy? Would this trigger a biopsy at year 3, the total normal function? I have one hand, 2. This is the biopsy showing normal histology. No C4D. The EM looks great. So they send him away. Year 5, again, he comes back with the same serum creatinine, however now proteinuria +1. The DSA is still present, perhaps a little decreased. Year 6, again, same serum creatinine, but now proteinuria +2. DSA is continuing to decrease in strength. And year 7, now proteinuria is at +3, a little alarming. They perform a cell-free DNA test, which is above the 1% cutoff. And however, to my HLA colleagues, the DSA to DQ5 is almost undetectable. It's well under 1,000 MFI, which many clinical labs use as a threshold. However, I would argue that the DQ5 beads are still stacking toward the top, and we confirmed it on a second assay. So I do believe that DSA is there, it's just there at very low level. Is it being absorbed on the graft? Is it being eliminated? They changed the tacrolimus to just once daily with an extended release. I'm not sure if they were still concerned about compliance. However, now when we do the biopsy, we see a glomerulus with thickened basement membranes, mild glomerulitis, a PTC score of 1, but very unfortunately, extensive staining for C4D and a CG of 3. And so it seems like it's too late for this patient. And so I bring it back, is HLA-DSA testing actionable when you have normal histology and when you have normal allograft function? Talking about before the proteinuria came on board. When do nephrologists act? And what is our DSA testing telling you? Is time since transplant of de novo DSA important? I actually wonder if we should think about DSA and chronic injury like the lung clinicians are thinking about it. Catherine Tinkham published a beautiful study in lung transplantation such that just detection of DSA alone as being a risk factor for chronic lung allograft dysfunction. And when they looked at just any detection of DSA, they found that DSA was detected prior to all chronic lung allograft dysfunction diagnoses. She didn't say what the level of the DSA was. She didn't say whether it lasted 6 months and then disappeared, but just evidence of a DSA, almost as though it's a biomarker for breakthrough alloimmunity. Not thinking of it in an injury way, but as a way of saying we're not immunosuppressing these patients well enough. Is the de novo DSA MFI important at all? Would you be more inclined to act with normal function if the MFI were over 10,000? Does that trigger different actions? And so I think we need to understand what the MFI is triggering and whether that's even relevant at all. Is it important to look for a DSA MFI change prior to treatment? So would you treat more aggressively if you tested, you saw a new de novo DSA, you tested 3 months later that de novo DSA was going up in MFI, suggesting a very active response? Would that change your treatment regimen? is looking at DSA post-transplant important? I think Stan mentioned that a decrease in DSA did correlate with eGFR improvement, so perhaps post-transplant, post-treatment DSA testing is important to know if you have efficacy. And then I didn't even get into the role of non-HLA antibodies, and do you test for non-HLA antibodies when your DSA is negative at time of index biopsy? Perhaps the non-DSA is contributing to the injury, but maybe the non-DSA is just a biomarker of tissue injury. So maybe it would be a useful thing, and maybe that's why when we see biopsies in which they have DSA and non-HLA antibody, the detection of both those types of antibodies, we think they could perhaps have a synergistic effect, but perhaps they're just a biomarker of increased injury. And so as I promised, I hope I elicited more questions than answers, and I would really enjoy a conversation and a discussion of what types of data do we need to gather to really understand when should we be DSA monitoring, how frequently. We do frequently monitor DSA in the first year post-transplant, and that is a time of high alloimmune response. But I just wonder whether we had studies that did more frequent monitoring over the long haul, whether we would understand the role of HLA-DSA in chronic ABMR. And so I would like to thank the organizers for bringing me to this beautiful locale, and this was a hike up to see Lake Moraine earlier in the week. Thank you.
Are there any questions? Please.
And I may be asking for nephrology help, because again, I am just an HLA director.
This question could go to everyone here. So it's my understanding is that DSA testing is done more in Europe than the United States. Is that correct?
I don't think so.
Okay.
Yeah, Emanuele?
Is there? So I guess my question is, why is there differences in patterns in terms of DSA testing? I'll just say, speak for the U.S. Why is there not a consensus on that? So.
I can tell you my experience with programs. So lung programs monitor it frequently and always all patients, and all the clinicians do it. In lung, de novo DSA occurs in a high percentage of patients, 40% of the patients within the first 3 months. So those programs are definitely looking at it. My kidney colleagues sometimes say, Annette, I don't know what to do with the result. You know, case in point, 5,000 MFI, de novo DSA to DQ, we know it's gonna be DQ, right? What am I gonna do with it? Patient has perfect function. I even did a biopsy and it shows absolutely no injury. So I have no effective treatment to clear it. I don't even know if I need to clear it. And so I would say that it's this unknown of what to do with the result sometimes, I think, that causes a pause in testing. And that is just my perspective.
Yeah, I think there are several factors. I think one is, what do we do with the DSA when we find it? The other question is the cost as well too. At $500 per test, if we're routinely screening that in a 300 transplant patient center, it becomes very costly. But at least in my experience, when I see patients with DSA and I go back and talk to them, usually I can find out there's a reason for the DSA. And I do feel as a physician for these patients, treating that DSA without understanding the cause and treating the cause, it's probably not going to have a material impact on their outcome.
Thank you.
So I'm a nephrologist and I may answer some of your questions. Clemens Buddha from Berlin in Germany and also from Europe. So we do routine screening for 20 years annually. So always the first time the patient shows up in our hospital, we do an annual DSA screening. Now the question is what to do with the results. And it's difficult because if you have no treatment, you cannot do anything with the results except what you said, that is to explore potential reasons, optimize blood pressure control for proteinuria, give ACE inhibitor, and talk to the patient about non-compliance. Mm-hmm. Yeah. And DSA monitoring in the first year is not really relevant in my mind because the problem is the long term. Yeah. 5-10 years afterwards. So because after 1 year you have, in the clinical trials, you have 3 or 4% de novo DSA, so 97% don't have DSA, so if you do more frequent monitoring in the first year, it's still not really a big problem. So the long term is the problem, and we just recently published, we finally got it published, a study when we looked long term. Yeah, and after 5 years, 1/3 of the patients go down the drain, 1/3 of the patients are completely stable. 1/3, yeah. And we should maybe look at those who are stable, and we always focus on those who go down the drain. And 1/3 is kind of intermediate. 10% of MFIs are lost over time. So this is also, so what to do with this? So maybe he loses it again or whatever. So this is, I think, our experience, and again, we're trying to focus more on this kind. There is also fluctuation. A lot of patients have fluctuating DSA, but this was kind of more of a risk factor for having a poor outcome.
So what about DSA monitoring the first year in patients that have repeated TCMR? You know, TCMR has been shown to precede de novo. So would that change practice?
So if you have a low-risk patient with no, so you could do it once, but I don't think, again, if you have no treatment, what is the
I know.
the issue?
Well, Stan brought up that perhaps we will have treatment. You know, perhaps IL-6 receptor or the IMAGINE trial with IL-6 blockade will offer us some.
With Georg, we are working on a different treatment option on IL-6 and so on, but so far we have no treatment.
Right.
That's it, and especially for those early cases, so we don't have a treatment. Of course, after T-cell mediated rejection, you can do maybe a monitoring, but T-cell mediated rejection occurs in low-risk patients in 10%, so and we know after 1 year, 3% have DSA, so what you want to more frequent monitoring in the first year, it's a waste of money. Spare your money for year 5, 6, 7, and 8.
At Duke, we're starting a new CTOT trial using carfilzomab and belatacib to treat in an attempt to eliminate the plasma cells in chronic ABMR. So that will be beginning next year. But you bring up excellent points, and if Peter Nickerson were here, I'm certain, I don't know if Chris Weeb is in the audience, but you know, we can risk stratify by molecular HLA mismatch to know who we should be monitoring. As I mentioned, this patient, it wasn't a bad class 2 mismatch, but there was a DQ mismatch, and DQ5 is quite different than DQ7. So it did not surprise me when the de novo was detected that it was detected.
No, so we strongly believe in epitope matching. I think this is really the way forward, and risk stratification with epitopes is a risk forward, definitely. Yeah. And we published on Birch and Matchmaker long-term outcome. So this is really true, and this is really biology. But the other aspect, if the guy stops taking the drug, you can have a, I don't know, Birch match or Applet match. And most of the patients have some intermediate, and if they stop taking the drug, forget all your theories, you have to talk to the brain of the patient. This is the problem, not the immune system.
Okay.
Thanks, Annette. That was great. Also, not a clinician, just an HLA person here. But I think your talk really highlights how much communication is needed between the HLA lab and the different clinical teams, and I think that's really important. And also, I just want to ask your opinion. I mean, MFI is not a quantitative value; it's
Correct.
semi-quantitative. So, you know, subtle differences like that. You know, maybe sometimes we'll run samples in parallel, old and new together in the same run to try to eliminate any run-to-run or lot-to-lot variations, but is that something you're doing in your center as well, or how do you handle that lack of sort of quantified?
So most of my career was at Johns Hopkins, and we never reported MFI at all. We reported Luminex positive, flow cross-match positive, and CDC positive as our it's kind of like a high, medium, and low. And before saying that there had been a change between those categories, we would run the old serum parallel with the new serum. At Duke, we're using the flow PRA. We run a flow PRA in addition to the single antigen beads, and we kind of look at the strength in the flow PRA and the strength in the single antigen beads. So we're using two assays to kind of normalize against each other to say, yes, we do believe this is an actual increase and an actual decrease.
Thanks.
Yeah, I think the comment about that DQ mismatch, the donor and recipient being relatively well matched is not necessarily true, because that DQ5, if you, well, so a donor with DQ5 and 6 with a recipient that's either 2, 4, 7, 8, and 9, that's, according to our data from machine learning, that's the worst kind of mismatch you can have for DQ. So
Right.
we're hoping to find a good place to publish it, but it's going to come out, I think.
Yeah, so perhaps risk stratification, along with all the clinical factors that you guys bring to the table at time of transplant, adding molecular mismatch to say these patients have a bigger alloantigen burden, and perhaps if you have a single pot of money, you should spend DSA monitoring on these particular patients. So being able to target the limited funds for post-transplant monitoring would be important. Thanks,
Yes,
Lauren.
definitely.
Thank you very much, Dr. Jackson. Excellent talk, and I just want to thank all the speakers. Oh, there's one more question. Sorry about that.
Sorry, Annette, great talk. Lots of questions, and I totally agree with you. I think sometimes we do miss it. But just in light of what Lauren just said about mismatch, if we know perhaps induction therapy could have prevented, this is where I think really knowing prevention is much better than trying to manage it once it comes up.
But what would induction, I mean, this DSA didn't show up until year 3. Did you really, I mean, is
we
there
don't
a
understand what happens early on, and we
Right.
aren't monitoring that closely. I think these transients may well be setting up something, and they may be creating memory that then pops up if the immunosuppression levels drop down again later. So I think we need better studies of this early
Exactly.
time period, but I find the more you look for it, the more there is antibody there that we may just be missing. But I do think the early events with perhaps induction therapy might mitigate some of these. And that's where the clinical studies are difficult, because they're a mixed population.
Right, but understanding when this DSA is truly developing and what is the context in which it's developing, and is it better to treat early before we see evidence of injury, or do we wait for first signs of injury to treat? Because treatment is not without its risk. And so all of these questions, and in fact I was going to pose to Megan Levins, if I were getting a Treg myself, if I was a transplant recipient, I wouldn't want an A2 Treg, I would want the DQ5. And I'm wondering, is it better not to even give it the first year when we know there's more alloimmunity occurring and a lot of more inflammation in the graft? Would it be better to get a Treg at year 1 when everything's kind of, perhaps we're at our most quiescent spot? Like, is that when we should hit them with Tregs? And then should we be specific for the DQ mismatch? Because we know DQ is the biggest target of de novo DSA.
Regarding induction, I think this is really not of any use, because we know with immunosuppression we can excellently prevent the development of de novo DSA in 97% of patients. So don't shoot all the patients for those ones who don't take the drugs. I think this is the problem. It's not immunology, it's about psychology of the patient and long-term follow-up care. This is crucial, and not some short-lived induction for the first 6 months where nobody anyway gets antibodies. Regarding the issue on detection of injury, I think now with the cell-free DNA, we have an excellent tool to detect patients who have injury in the kidney graft in ABMR. I think this is, it really comes out, all studies ever and ever again, and I think this is the way maybe you could stratify those who want a biopsy and those you could leave alone.
I think understanding when DSA is actively contributing to injury, or if it just starts this wounding process, is really important.
Final comment?
Yeah. Thank you so much. So, lovely talk, and again, a very important discussion, and we won't resolve it here, but I will say the following. It's a combination of identifying the population at risk with regards to underlying incompatibility. And I would say the following. We can blame sometimes patients for non-adherence, but there are contexts whereby it's not necessarily the patient being non-adherent, is the context of reduction in immune suppression that it's justified in a particular context or a complication, or over time, it might be that again, there's a natural gravitation towards reduction in immune suppression, co-medication, and so on and so forth. So knowing those patients in whom it is likely that eventually there's going to be, for whatever reason, reduction in the needed immune suppression given the underlying mismatch is what we need to study. And for that, we need longitudinal data. The other comment that I will make is the following. As we strive to understand the meaning of DSA, HLA DSA, and on top of that, looking into non-HLA, I would argue that we need to longitudinally look at both at the same time.
Yes.
Not just in the context where DSA is not detected. We know that that interpretation is, I would say, standardized interpretation and conduct of the assay is undergoing. So much more to do, but I think we are moving in the right direction.
I think we have the tools to do it. I think we have MMDX, we have blood transcriptomics, we have cell-free DNA. Certainly, we have the tools to really understand the pathophysiology of the injury and the progression of the injury, and just very well mechanistic studies need to be done.
One final comment.
Because I think that this is one where I hate to say this, but sometimes there's like patients are taking medicine, but I think the one thing that if you really acknowledge and look at post-transplant, I'll speak for the United States, there's a real struggle after the transplant. The patients don't really get much direction on that, right? So you're speaking to someone who's 18 years out, I can figure it out on my own. And so I think that's just a field of study that's really not really understood. So I would just suggest when you look at non-adherence, think about how much we're spending on the back end. In the United States, we're going to spend as much time on it. The system doesn't support it. So just,
Right, and I would say, I mean, as a laboratorian, I was so impressed with the at-home COVID testing. Like I thought it was amazing. And so, we're coming toward that. Home DSA testing, pee on the stick, let's detect, I mean, why can't we detect DSA if we can detect COVID? I think there are panels we could make, like a CPRA on a dipstick, and if the patients go on a holiday, they forget their meds, they go for 3 days, with less medication, they come back, allow them to test themselves a week after. If they see a signal, come into the clinic, have an actual HLA DSA test. I think we can put into the hands of our patients more tools that they can know when to come in. They know when they've been sick and they've been throwing up their medication, and give a little more power and knowledge to our patients. It's going to be more expensive, but I actually think there's a lot more subtle noncompliance just because of life than we realize, and that's going to be an important thing.
well said.
So like cell-free DNA home test.
Home test, yeah. Something,
It's cheap enough that this is sustainable.
yeah.
Thank you very much again, Dr. Jackson. So obviously you elicited a lot of discussion. Again, thank you to all the speakers and the audience for a wonderful participation. It was a great morning session. Thank you so much.